Hey everyone, this is Dr. Jessica Bauer from IVFMD, and we are live now with Dr. Farrar Duro of Florida Complete Wellness for our Fertility Live Q&A. Let me get her going, and we will get started. Hopefully she will arrive soon. I hope everyone had a nice Wednesday. There you are.
Hi.
How are you?
Good. How are you? Good.
Good. Another Wednesday in the books.
Yay. Excitement. We have so many good questions too. I'm excited.
I know. Do you think we should jump right in? There were a lot this time.
Yeah, definitely, and definitely everyone else is free to chime in as well if you guys have questions. But that's what we're here for tonight. So
Absolutely.
thank you.
Good. Let's see. I think the first one I see. Sorry, I'm looking at my computer, which is over there. So that's what I'm looking at the questions. First one is in Spanish. She's 43 years old. Normal, like a healthy, normal 43-year-old. Can she get pregnant naturally? And the answer is, of course, absolutely. Of course you can. You know, are your chances of conceiving at 43 less than if you were 33? They are, but there still absolutely is a chance. The thing that I would say is that it's important to understand that as egg quality declines with age, there is a higher risk of what we call aneuploidy, or a chromosomal issue within, if you conceive naturally. And so that's something to be on the lookout for. And certainly if and when you do conceive, there are certainly measures to take with your primary OBGYN to screen the pregnancy for any sort of abnormalities and whatnot pretty early on. So that is reassuring, but definitely you can conceive a normal pregnancy at the age of 43. It's just a little less likely.
Definitely. Our massage therapist, I was just talking to her the other day. She had her last child around 45. So,
Wow.
and she works with our patients all the time during pregnancy as well. And, her baby was breech, she had all these issues. So it's kind of, I think it's inspiring. We see that, it can definitely happen. You just have to have, I think, a little bit of luck on your side, some genetics, and then, also working with practitioner if it's not helping, if it's not happening on its own. So yeah.
Definitely. And it certainly can happen. I often get that, people are like, oh, I know someone that conceived on their own at 45. Like, why can't you do IVF at 45? Or, questions like that. And that's always a tough one. I guess like the message I try to convey is that getting pregnant on your own at 43 is very different than taking you through fertility treatments at 43. They're kind of like apples and oranges. You can't really compare them, but it doesn't mean that it can't happen. It's just, you have to be educated about what your chances are. That's it.
Definitely. And there's so many options, which is awesome these days. We just like
Absolutely. Many options.
Yeah.
I have any signs or symptoms to be expected after FET or frozen embryo transfer that could suggest a pregnancy. So this is a tough one because there are plenty of people that feel absolutely nothing, and there are plenty of people and feel absolutely nothing and have a wonderful, healthy pregnancy. And there, unfortunately, are patients that have very significant symptoms that potentially, they don't have a successful embryo transfer. So it's a tough question to answer because every patient is so different and you really need to, individualize yourself. But in general, nausea and significant breast tenderness and, in general, those kinds of early pregnancy symptoms are generally a good sign, but it's not always a guarantee. So
Right.
That's
the
a
most
tough
frustrating thing. It's like everything feels like your period's coming on, and then it's
right.
Is my period? Am I pregnant? And then you have progesterone on top of it, and you're all these factors. So it's really difficult and then testing early also is a problem sometimes. And I know you have that where patients like, I just want to know, but then sometimes it's too early when you're testing, and you know. And some
that's the
patients we
big.
saw, it was actually not positive to the morning they went in for the test. You know, it was like negative, negative, and then boom, they went in, it was
All of a
positive.
sudden
So,
positive. Yeah.
yeah.
There's a reason. There's a method to our madness. That's why we tell you to wait until usually it's about 9 days after an embryo transfer, give or take. And that's when you are most likely to see the positive based on how implantation occurs and whatnot, but it's very hard to wait. I totally understand.
Yes. I know. I don't know how everybody does it. We just do a lot of meditation and breathing, distractions. So many
Acupuncture, you should do
distractions, yes, acupuncture, all that. So that's all
yeah.
good.
Yeah, for sure. Um, let's see. I have
Yeah,
day
another,
5.
yeah, day
Oh,
5. Okay. Yeah. I
yeah,
was just
day
looking to
5.
this question.
Uh-huh. Day 5 after fertilized, after the embryos were fertilized, I presume, both embryos degenerated. Any idea why? Second IVF failure. And first of all, I'm so sorry. That is, can be, devastating news when you're going through this process. It's very hard for me to know without having more information or knowing, about your particular case. I can certainly tell you that, egg quality and sperm quality are the two main things that go into whether or not IVF is going to be successful. And so if you have either of those issues for whatever reason, they are very likely the contributing factor to what's going on. I would definitely urge this person to, especially now, have a sit down with their doctor about and review each of the cycles and what has been done and what potentially is the source for the failure that has occurred, so that you can decide what is the best way to move forward. So
We wish you definitely lots of luck.
we wish you lots of luck. Yeah. That's a tough spot to be in.
Yeah, her doctor doesn't know why. That's what she's saying on here. So maybe that's a time where you might want a second opinion, right? I mean, if you're kind of at the or not sure like which route to take, it maybe doesn't hurt to just get a second pair of eyes.
Absolutely. Sometimes fresh set of eyes. And at IVFMD, if you provide your records to us in an amount of time that I can review it ahead of time, we offer free second opinions. So it might be worth getting that information, and just like Dr. Duro said, just a fresh second set of eyes. And I would definitely encourage you to do that.
Okay, it looks like she does go to IVFMD, but
I'm an IVFMD patient.
well,
Okay.
In that case, I guess in general, like maybe there are different treatments that haven't been done or that sort of thing.
Absolutely. There are definitely indications for trying different routes for again, if there is a significant egg issue or a significant sperm issue. Sometimes considering the use of a donor can vastly improve your chances. But that's a discussion that needs to be had between, of course, you and your partner, and of course you and your doctor. I'm not saying you have to do that, but very often, if there is an egg or a sperm quality issue, that can make sense.
Mm-hmm. Yeah, and I mean, sometimes like even if the partner looks healthy, we still like say, look, it's good to support them as well nutritionally, give them on like a really good like male prenatal, or vitamin geared towards fertility in general, just for a short period of time. It's not going to hurt. And sometimes you can see changes there, and really optimize everything you can before that next cycle if you have a chance to do that. That would be great.
Yeah.
There's a question that popped up here. You're seeing about a small uterus tipped with PCOS.
I have a question regarding small uterus tipped PCOS. Doctor prescribed estradiol from cycle day 1 to 21, and letrozole from day 3 to 7, and progesterone from cycle day 16 for 10 days. Does this estradiol prevent ovulation? No, it doesn't prevent ovulation, but if you're giving, in my opinion, I think what they're trying to do potentially is sort of like an estrogen priming scenario to get your ovaries to respond. But letrozole and estradiol sort of have opposing mechanism of action at that point. I'm not sure. I particularly would not necessarily choose this kind of protocol for PCOS, but again, every PCOS patient is different, and again, it's a little hard for me to know exactly what is going on at this point. I generally don't find supplemental estrogen, especially when using letrozole for ovulation induction, to be particularly helpful. But I'm not saying that there couldn't be scenarios in which it could be. So not something I particularly do, but doesn't mean it's necessarily wrong. Just not necessarily something I would choose.
No.
Yeah.
That's a very specific question too.
Yeah.
And let's see, I think we had another transfer question too. So I know I saw a bunch of transfer. Thin lining. What causes a thin lining? Yeah. That could be
Thin lining. Thin lining it's like one of my least favorite things to because it can be super, super challenging. So there are a couple of things. Number one, someone who has had extensive surgery on the uterus or scarring in the uterus can cause a thin lining. Poor blood flow to the uterus can cause a thin lining. If you have like a calcified uterus, or if you're a little bit older, if you have high blood pressure or something like that, that can cause thin lining. What else causes uterine thin lining? Let's see. There's structural reasons, there's hormone reasons, and the doctor really needs to sort of parse out exactly what you're dealing with. The problem is getting it to respond to medications can be really, really tricky. There's sort of emerging evidence to suggest that our initial thought of like everything has to be over 8 millimeters and 8 millimeters thickness is like the be all end all. There's some like recent evidence to suggest that, some people, the best they can do is 6.5, and that's okay. And as long as it sort of structurally appears normal, that could, potentially be beneficial for some patients. It's a tough question to answer. But I do know that, especially if there's a blood flow problem, that I always, and at least if I know about a lining problem, I always encourage patients to really have a strong like acupuncture regimen going into the preparation for the embryo transfer process, if that in fact is what you're talking about in terms of a thin lining. Because the consistency is going to be where you're going to see the most benefit, and certainly Dr. Duro can speak more knowledgeably about that, but my 2 cents.
Yeah, definitely. And sometimes we see it in over exercising too, like patients like, I exercise 4 times a week, or they're doing a lot of cardio. It just seems like it's going against what we're trying to do sometimes,
Yeah.
so it's like, well, we need that blood flow not diverted, away from the uterus. We need it to actually go towards the uterus. So that's important. There's other ways we can help with that as well. Somebody actually asked a question about laser acupuncture, which I want to address in a little while.
Yeah.
But that's actually from Japan, actually, some research about that. And so that's shown to improve blood flow. So in Doppler studies and thermography readings and different things. So so that's a non-needle technique. If you're if you don't want to do acupuncture, that's it's called, well, some people say laser acupuncture, but it happened that, and I'll just address it now since we're talking about it. In Japan, there was a doctor who was treating low back pain, and a 55-year-old woman with cold laser, which is 830 nanometer. It's a little cold laser wavelength that is used usually we use it for inflammation and pain. Well, it actually, after a few treatments, she started spotting, and then she got her period. And he's like, what's going on? And then, he kept treating her. He didn't think it was related. He kept treating her back pain with the laser. And actually low down on the sacrum and all of that through there in certain points. And she got her period again. And she actually came out of menopause. It's like she started ovulating again. So they're like,
Wow.
what's going on with this? So they actually formed some sort of, it was in Tokyo in a hospital. They said, let's just try to study this a little more and see if we can get, we can improve fertility in women who have failed multiple IVF cycles. So they took the, I guess the worst case scenario of people who had 8 or more failures of IVF. Yeah, so extremely difficult cases, the most 100 most difficult cases, and they got a 26% pregnancy rate out of that group. So that just doing laser, and some of them they combined it with that IVF, and some of them a couple natural, and then some with even like Zift and different techniques. But
Oh,
they
wow.
actually got, yeah, they got a really good I mean, that's actually pretty good for
That's great
very
for a very poor responder, for sure.
exactly, yeah. And they noticed the ovaries actually got bigger, and the follicles can improve. So we do use that laser in our practice. A lot of times we use it for pain relief, but we also alternate it sometimes with the acupuncture when someone does have that diagnosis of issues with, like, smaller ovaries or poor response to medication, that sort of
Yeah.
thing. And it's very gentle. It takes about 5 seconds per cycle. So we do about, like a minute or two in each spot, and you do about 5 points. So it's really not, it's not invasive, and it's something that, could be also helpful. There are a couple of new of IVF clinics doing this during transfer as well. So the question
Wow.
was, is it helpful pre and post transfer? So that's another option too. But yeah, it's really interesting. It was published in Fertility and Sterility back in 2008, so it's been a little while. But
Oh,
there's
yeah.
been, like, it's growing, and now people have noticed that when they looked at blood flow, like if you had a lining issue, I would probably recommend that and say, let's do
Absolutely.
some laser acupuncture along with the acupuncture and try to work with that. And maybe herbs as well if you have time, if you're, but try to work on that beforehand if you know it's an issue, instead of
Yeah.
just like trying to force it when you're, preparing for that transfer and you're upping the estrogen, nothing's happening. It's frustrating.
Right.
Maybe there's some other ways, techniques to try. So, yeah.
Yeah, absolutely. Which herbs are I very often get herb questions, like, from my patients, and I feel not so educated about it, but what herbs are best for, if you were like putting together a regimen for a thin lining patient?
Usually some of the formulas are phytoestrogenic, but they're safe. They're not going to interfere with the receptor sites or anything. If you're adding estrogen to the protocol, it's not going to interfere with it, but it might accentuate it a little bit.
Got it.
So, a lot of the formulas are multi-herbal formulas. So there's, like, 10 to 12 different herbs in each formula, but they're
Hmm.
all working synergistically. So we're not
Okay.
giving, for instance, like one thing, like, okay, red raspberry leaf, it might be okay in certain instances, but we want to actually use formulas that have been used for many, many hundreds and hundreds of years to
Yeah.
work with restoring cycles. And when we see them, when we use these formulas on patients who are not doing IVF, their cycles are getting a little bit fuller, a little healthier, more bright red flow, that sort of thing. So, so those are the ones that we typically use that are gentle and safe, and they're, tried and true formulas. But once we start, any IVF medications, we generally, we stop the herbal treatment, because hopefully we've been doing it enough time for it to actually work.
Right.
So
Got it.
it's already, yeah, it's had its time, and now the lining is nice and healthy. Hopefully, we'll at least start it for like 3 cycles. I would probably do that going into it. Of course, if you don't know your lining's an issue, then that's not a thing. But hopefully you're doing acupuncture and you're doing everything you can. We also use fertility massage too. We have a massage therapist do, definitely like a little bit of abdominal massage, lower back, all that as well. And I think also when you're less stressed, your circulation can improve as well. So that's always, it's like a fight or flight response. So.
Yeah,
Um,
for sure.
so, yeah.
Cool.
So I think I answered the laser question ahead of time, but
Yeah, no,
hopefully
that's all right.
that helped. Yeah, because I think that that was one of them. Yeah, that was asked earlier. So
Perfect. Do you always use baby aspirin before transfer? If so, when to stop? The vast majority of my patients, unless there is an allergy or some other contraindications, I do use baby aspirin leading up to a transfer. And then I would definitely continue it through through the first trimester, there's some evidence that it can facilitate placentation, or like generation of the placenta, and how it adheres to the uterine interface, and also potentially decrease the risk of preeclampsia. So I'm pretty generous with my baby aspirin. Again, you have to make sure it's the right choice for the patient and that there's no contraindications, but I think baby aspirin's a good thing.
Definitely, especially with COVID, you know, they're saying like, even if you had it or if you're exposed to it or who knows what, but that's one of the you know, they try to work with blood flow. So I think, you know, would you recommend them continue it through the first trimester, or just like when does it usually end?
I mean, given that I just said that it's, you know, related to placentation, you know, that usually is complete. Even it can be anywhere from 6 to 8 weeks that is done. The first trimester is sort of a nice stopping point, an easy one to think about in terms of, you know, I don't think you're going to do any harm by continuing it. The state of pregnancy itself increases your risk of blood clots and whatnot. And again, it has to be in the right patient, of course, not for everyone. I can't stress that enough. But, you know, I think there's very little risk to it if you were to continue it through the first trimester. But if you wanted to stop it around 8 weeks, something like that, I think that would also be reasonable.
Very cool. Yes. Let's see. We have one on. Oh, let me see here. We have so many good questions, guys. Thank you.
I know. This one looks other antibiotic regimen. This one will be relatively quick for chronic endometritis besides doxycycline. My go-to after doxycycline, if that doesn't work, I will either do Augmentin, or sometimes if you add Flagyl or metronidazole onto the regimen, it can help clear the endometritis for sure. So those are my go-tos if doxy doesn't clear chronic endometritis in the first round.
Awesome. And I think we missed a question from the feed that's somebody listed here. Actually, there's a few. Well, wow, there's a lot. Sorry, let me get these here. Okay. It looks like, is there a high chance of multiples with IUI?
So there certainly can be. You know, certainly if you're using Clomid as a medication, about 5 to 8% chance of twins. If you're using letrozole, that number's slightly lower. You know, maybe 3 to 5% compared to Clomid. But the idea behind why IUIs work and some of those medications is that instead of bringing up one follicle at a time, you bring up more than one, so that it increases your chances of getting pregnant, but it also increases your chances of multiples. So the quick and dirty answer is yes, it does.
Oh, yeah. I mean, now that I guess, have you seen a lot of twins though with IUI, or I mean, I don't know.
I have. I mean, of course, over the years, you see everything, but you also, you know, there are scenarios that if a patient in particular like really over responds to a medication and they have like a lot of follicles, sometimes it's not appropriate to proceed with that cycle because the risk of what we call high order multiples, which is more than 2 babies, so 3, 4, 5, is, if that is a real concern, then it's not safe to, you know, proceed with something like that. And that's always a conversation that you need to have. And that's why we monitor you on those medications, because everyone can respond so differently. So I've definitely seen twins and triplets from IUI, and it's one of those big misconceptions that IVF is mostly the cause of twins and you know, triplets and whatnot, and it was, you know, 15 years ago before we had genetic testing, but now we're really putting back, you know, almost, you know, as much as we can, we're putting back one embryo at a time, because having, you know, one baby at a time is what's healthiest for, no matter who you are or how young you are or how healthy you are, having one baby at a time is healthiest for you and for baby. So
no, for sure. And how do you prepare for FET? Does the place where you get acupuncture make a difference?
I can take the first part. So you prepare for FET with with usually an estrogen product, whether it's a patch or a pill, to build the uterine lining. And then you start a progesterone, usually through an injection or a pill that you put vaginally. Sorry, I got a little four-legged visitor coming in. um, and so that's how you prepare for it. You build the uterine lining to make it nice and thick, and then you lock it in with progesterone to make sure that it is receptive to the embryo when you put it in.
Yeah, and how we help you prepare is basically we work with our patients usually once a week if we have time, if we have a few months prior to that transfer. If we have, and then about 6 weeks and prior to the transfer, we do treat our patients twice a week with acupuncture. And try to get those treatments pretty scheduled in so that, you know, by the time the transfer rolls around, you're a little bit more relaxed, you're prepared, everything looks good, and, you know, you're feeling good going into it. And then if our patients do, or your patients want acupuncture at the transfer, we try to arrange that as well by being on site. And if that's not possible, we can do the treatment as close as we can to the transfer. We just don't see any patients after the transfer immediately. We wait 4 to 5 days at least, because we like everyone just to rest and go home and, you know, relax a little bit, watch funny movies, and just kind of, yeah, not worry about racing to an acupuncture treatment and that sort of thing. That really is not helpful. And I mean, I think the place that you get your treatment should be one, obviously, that you're comfortable with that person. You and look forward to that during the week. Like, you don't dread it. It's not causing you additional stress. And hopefully the person has, you know, experience working with similar patients that, you know, like you. And so there is a website called aborum.org. I usually give this website out and I'll type it in the comment section, but that site, it actually has a list of practitioners by zip code, I believe. So I'm also certified by them, and it basically is for reproductive acupuncturists. So that way, you know, wherever you are in the world, hopefully you'll find one of us to help. And you don't have to obviously have someone who's, you know, certified in oriental reproductive medicine, but it's helpful if you're going through this particular treatment, you know. So hopefully that answers that. And
Yeah.
yes, and there's another question right after that. We didn't see it, sorry, but it says, I'm 38 and I got pregnant naturally right after HSG now. I've been spotting since last Wednesday. Ultrasound last Thursday measured me at 5 days and 6 weeks. Bleeding stopped today. Any encouragement?
Absolutely. Absolutely. 6 weeks and 5 days. If you have an intrauterine pregnancy, that's half the battle, and it can be very, very common to have a little bit of spotting. The fact that it has stopped is very good. I'd recommend, you know, what we recommend is pelvic rest for you at that point. You know, no intercourse or nothing in your vagina other than medications if you're supposed to be taking those, and lots of hydration and whatnot. And usually, your doctor might consider seeing you in a week or two afterwards, and just keeping the doctor, you know, up to date on, you know, if your symptoms change or anything like that. But it can be super common to have bleeding in the early part of pregnancy. So
I think that's
stay
one of
cautiously
our
optimistic.
I'm pretty sure it's one of our patients too. I'm like, that name sounds familiar with but if yeah, I believe so. I think it's a scary part of when you're bleeding a little, but it's not uncommon, you know, and that's the thing, right? So
Yeah.
it could be a good sign of implantation too. But I mean, I think like that's super encouraging too, that your body knows what to do. And right, I think the miscarriage rates go down pretty dramatically after 6 weeks.
They do.
I mean, there's always a chance, but it's definitely less.
Yep.
Right.
They go down even more if you see a heart rate, see a good heartbeat.
Yeah. So yes,
Yeah.
congrats.
Yes, congrats. I was trying to look. On progesterone, do progesterone suppositories work just as well as PIO or progesterone in oil? Can progesterone suppositories cause a chemical miscarriage if they aren't adequately absorbed? So recent data suggests that progesterone and oil. Farrar is absolutely the gold standard for progesterone supplementation for IVF. It has the most reliable absorption and also the most reliable way for us to monitor your levels when you're doing. Hold on one second. My husband has the TV. It's so loud that I can't hear. Mark?
That happens.
Mark! He can't even hear me. It's so loud. Let me close the door.
We can't even hear it. No, it's okay.
Really? Mark, turn the TV down. Good Lord.
That's what happens when we go live.
There's no, it's not like he doesn't know I do these all the time. I apologize, everyone. Excuse me.
It's usually, it's like last week it happens where, last live, there was a neighbor like blowing leaves on his driveway at 8 o'clock at night. I was just like outside thinking, this is going to be the quiet part. And then it happens. Yeah.
It does. Life happens. That's what happens when we do things from home these days. So anyway, my long story short is that there was a recent paper, I think it was in Fertility and Sterility, suggesting that progesterone and oil is really the best way to go, is really the gold standard in terms of good progesterone supplementation. And I do not believe that progesterone suppositories can cause a chemical miscarriage. If you're putting suppositories in the vagina, they're almost certainly going to be very well absorbed. There's just better data to suggest that the progesterone and oil is going to support you better, in my opinion. So, and sometimes I use both, because you never can. Is there such thing as too much progesterone? Probably, but but we like to be pretty generous with it. So
yeah, definitely. And I think it has like a little bit of a calming effect too. Certain times I see
it slows everything down.
Just sleepy. Yeah, it's like, I feel good.
Yeah.
So there's a few questions about IUI and rest time. Do you guys recommend people rest after IUI or?
I do not. After how many? Oh wait, after how many IUI you need to rest? Does that mean take a break from IUI or rest after IUI? I don't know what that means. Either way, I don't recommend that you necessarily need to rest or do bed rest or anything like that after an IUI. You can really resume normal activity. If you mean how many IUIs should you do before taking a break or moving on to something else, generally I say about 3 to 4 IUIs before you consider at least having a conversation about trying to move on to something else. So I'm not sure what they meant by that, but they're both answers.
And someone asked the French fry question again, I noticed. So
I
answered that, and we posted that.
We totally answered that.
So go to our Instagram, go to IVFMD, or go to FL Complete Wellness, Florida Complete Wellness, because we posted that response to the French fry, the infamous French fry question. On
quite infamous.
Yes,
for sure. And then the next one was the lower laser therapy question. So I think we addressed that unless you want to talk more about it.
No, but it's just definitely something you can research it if you want to Google, cold laser IVF. So it's pretty neat.
Nice.
We'll research it.
And then we have, what are your thoughts on a 6BC graded embryo? It's a good quality embryo, it's hatching, the inner cell mass has a good quality, it has a good grade. And then when you have a C graded trophectoderm, or the part of the embryo that becomes the placenta, a C, it really depends on which clinic you're using. So it's very variable. A C can mean like just below a B, and a C can mean something that is really quite poor. So the downside of grading is that it can be very different between different clinics and also between different embryologists. But I certainly, a 6BC would absolutely be one that I would consider for transfer. Absolutely. So I would definitely stay positive about that one.
Mhm. Awesome. And why might my LH surge levels be 3 times higher this cycle than in my previous 10 cycles?
Yeah, I think the same person asked the same question on my Takeover Tuesday, which was
Oh,
yesterday.
okay. Oh, okay.
Um, and what I said then was, again, a little hard to know. Certainly, if someone is utilizing like a trigger medication or something to induce ovulation, that can certainly result in a higher LH surge if they hadn't been using that previously. If you have been doing other interventions to make yourself healthier, to if you're losing weight or if you're overweight, if you are using supplements to help improve your ovarian function, all doing interventions can certainly result in a higher LH surge. But the other thing that is very important to understand, and I'm not sure how this person is checking their LH, but LH is what we call a pulsatile hormone, right? So it goes up and it goes down, it goes up, it goes down, and you very well could have just caught it on an upswing as opposed to a mid swing or a downswing. And so that it's a tough question to answer. I would say that I'd be happy that the LH surge has improved. Certainly, we want to see a robust LH surge. That's always going to be what you want. But like I said, interventions are probably the most common reason why the LH surge has improved. Yeah, that's kind of what I
Yeah.
think.
And I wonder if this person's trying naturally, or are they
Yeah,
doing like any medication, or because this is just 10 cycles, so I'm not sure if they're using ovulation test strips and they're just darker now, or I don't know. But I
yeah,
mean, definitely if it's been 10 cycles and there's nothing happening yet, and I would definitely want to check that out and see what's going on, especially if you're
absolutely.
ovulating too. Like you're ovulating, but nothing's happening, so
Right. Yeah, no, that's a good time to sort of do a gut check and say what's going on, and maybe I should just because you see a fertility specialist doesn't mean you have to do treatment. Sometimes it's just uh, a time to educate yourself and get some information. No one's gonna. I think people are afraid to come and see us because we tell them that they absolutely need IVF, but that's definitely not the case for sure.
Mhm.
There are definitely people that just need some lifestyle adjustments or minor interventions to get the job done.
Right. Yeah, don't be afraid of needles, and don't be afraid of IVF doctors.
We're equally as friendly. Yes.
Yes, we're just trying to help.
Yes.
Okay, and the French fry question
There
is
he
that
is.
it's okay to have French fries, but not probably very beneficial, right? If you were to sum it up.
Is the summary. Go ahead and have French fries if that's what's going to make you happy. Is it not going to? It's probably not going to improve your chances considerably. But if maybe if it makes you feel better and helps you feel better, then go for it. No problem on my end.
Yes. And then are there ways to save on IVF? Insurance won't cover IVF or anything infertility related.
Yeah, it's really, really tough. I hear you on this one. It's one of the biggest downfalls in my field is that a lot of what I do is not considered by insurance, to be medically necessary or things that fall under their coverage windows. I would say that there are ways to you never want to if you're investing in IVF, which is is not just a financial investment, right? It's a physical, emotional, psychological investment. You want to do it right and do it once and give it your all. And so I wouldn't recommend skimping out on things. If your doctor is recommending a specific medical plan, I would say do your very best to try to go for it. There certainly are like programs that can assist you with payment plans. If that's an issue, I do know there are certainly scenarios where you can have like donated medications and stuff like that, or some pharmacies offer, you know, discount. Um, some fertility pharmacies, I believe, offer some, you know, discounts if you're buying a certain amount of medication. So look for those kinds of things. It's a really tough one to answer, one I wish I could help more with.
Definitely. There are some groups, like you mentioned. I did a search the other day for someone that, you know, it's like they provide grants, like things you don't have to pay back. So,
Right.
and we actually have a patient working on developing I guess like a charity or some sort of organization for women who are going through IVF to help them pay for their acupuncture treatments. So that's pretty
Oh,
cool too.
that's great.
That's something that's just starting up, but we're hoping to help with that. And so it's out there. I guess you just have to search sometimes, and hopefully it will not take very many cycles. Hopefully just one, you know, to get to that point. So yeah.
Yeah.
And the good news with the freezing, how, you know, and I remember starting many years ago, it wasn't like the technology wasn't there to freeze eggs, and you know, it was kind of iffy about thawing embryos and all those things. Like it really has come a long way, and I think like we talk about egg freezing a lot and things like that, but I think if you have a cycle that's successful and you do have frozen embryos, that's a benefit to not have to stress about that when you're pregnant, thinking, oh my God, I got to do this all over again. Like you
Right.
have in the bank, you know, and you can literally just take your time, you know, with having that second child or third child, you know. So we're pretty lucky that we're living in that kind of scenario now. I think back, well, it wasn't that long ago, but like
Yeah.
maybe 12 years ago, 15 years ago, it really wasn't, you know, like we didn't know. Our donor patients who were doing donor cycles, they were doing fresh donor cycles. They were not, they didn't even have frozen embryos
Yeah.
to pick from, you know, or
Right.
frozen
Right.
eggs. So I think, you know, sometimes it seems like a lot, but if one cycle can hopefully yield like 2 kids, 3 kids, like you never know. So that's the scary part, is it's a gamble, but you got to
It
jump in there
is.
sometimes. You
Yeah,
know,
for sure. Life's a gamble, though, right? In general.
yes, it is. Hey, driving on the Palmetto, it's like it's
Oh,
like a gamble.
that's even. I don't even. That might just not be a bad idea altogether.
Yeah, that's, oh my gosh. Yeah, that's great. So there's a PCOS question that we have as well. I have PCOS and haven't had my period for 2.5 months, but my lining is about 4 millimeters. So that person's not ovulating, I would think, right? I mean, what
Correct.
would you
Yeah.
say? Yeah.
Yeah.
Okay.
They're certainly not ovulating, and the fact that they have a thin uterine lining suggests potentially that they might, in addition to not having, you know, adequate exposure to progesterone, might also be slightly deficient in estrogen. And so, usually, when you in PCOS, if you have a patient um, that has not had a menstrual cycle, you can sometimes induce a menstrual cycle with a progesterone medication called Provera. But if the lining is very thin, Provera can only work if estrogen is around. And if estrogen is around, generally you'll have a thicker lining than 4 millimeters. So um, one suggestion is possibly to induce a menstrual cycle with actually a birth control pill, which may sound counterintuitive, but if you take a birth control pill for, you know, a couple weeks, and you're exposing yourself, because a birth control pill has both estrogen and progesterone in it, if you're exposing yourself to both hormones, that can induce a menstrual cycle. In some PCOS patients for whom Provera or a progesterone only medication doesn't work. And that's what it sort of sounds like to me. One of the telltale signs of having lower estrogen can potentially be, you know, a thinner uterine lining in the absence of any menstrual cycle.
Yeah, definitely. Yeah, because you always think about it being the opposite. If you have PCOS, you have a thick lining, you're not having your cycle, you know, like it's, then you have that big heavy cycle at the end. So, but yeah, I do know that some women with PCOS are estrogen deficient as well.
Mm-hmm.
So that's
Yeah,
important to test your hormones. Very important.
absolutely.
So,
Yeah, for sure, for sure.
and then another question about how long should acupuncture be done? I think, you know, like if we have that preconception window where we can work with you for a few months prior to that IVF cycle, that would be optimal. It's not always the case, but you know, sometimes if, like for instance, we have patients that are thinking, okay, I have a plan. If I don't get pregnant naturally, I will try, you know, a medicated cycle in about 6 months or 1 year even. So they already have this sort of, you know, plan in place where they will try, you know, to do acupuncture, herbal medicine, changing their diet up, you know, making sure their labs are optimized, getting, you know, getting rid of some of the excess stress in their life. That's sort of their preconception plan. So that's what we try to help with as well. Like, can we, you know, try to get that stressor removed? Because if you don't have a plan, you're just kind of like, okay, I needed to get started on this right away, and what do I do, and all that, and it becomes like, you know, another stressor that you have in your life. So, so you know, give yourself that time to, if you have a few months, and I would say that if you take out 3 or 6 months out of, you know, I guess before you start IVF, it's not taking away anything. I think that it's just adding to the benefit of, you know, helping prepare for your treatment. And if you get pregnant naturally in the long, you know, while you're preparing, that's great too, you know. And then, you know, if not, we work on, okay, look, we've done everything we can and we've gotten to this point. So now this is the transition time where hopefully everything will work much better because, you know, your blood flow is improved, your stress level is improved, your nutrition's improved. All those things, you know, have gotten you to that point. So, and you know, our goal is to help you have a healthy pregnancy as well. So it's both of our goals, Dr. Bauer and I, you know, to make sure that, you know, we see our patients throughout pregnancy too. So a lot of times it's kind of a very boring, uneventful pregnancy, which is awesome. There's not much, you know,
the best kind.
Like, yeah, it's just like, well, what do I do now? I'm not at all my appointments anymore. I don't have all these ultrasounds and labs and everything. It's like, no, I mean, you go once a month, just like a normal pregnancy, you know, to your OBGYN, and that's it. So I would do it, yeah, to answer your question, you know, at least minimal, I would try to do like 4 to 6 weeks prior to a medicated cycle. If you're trying naturally with doing acupuncture, at least give yourself 3 to 6 months for that treatment to really to work, and see if it does work for you. If it doesn't, at least, you know, you're ready for the next step, hopefully. So
absolutely. I think you hit on, well, we answered the other one, but you hit on your other 2 questions with what you just answered. So that was good.
Oh yeah, I did that. I looped everything together. That's good. Yeah.
Good job.
Yes. Yeah. After a transfer, like we said, we do acupuncture 4 to 5 days after the transfer, twice a week till the ultrasound shows a heartbeat, and then once a week during the first trimester. And then after that, it's just as needed. You know, it could be, some patients still come maybe once or twice a month just for, you know, low back pain or migraine. We actually do have patients that have migraines. They had migraines prior to pregnancy, and they're coming during pregnancy to prevent those migraines because they don't want to take their, you know, medications, or they don't want to take Tylenol, all that stuff. So, so that's one reason why we might be treating during pregnancy. We work with some OBGYNs that are actually referring their patients for acupuncture during pregnancy for low back pain as well. Because it's one of the safest things you can do. It's really gentle, and you don't have to take, you know, pain relievers and that sort of thing. If you can,
yeah, I bet sciatica too, right? Because that's
sciatica big time, because all those ligaments are being stretched. You know, you've got a lot going on in the QL and the quadratus lumborum area where it pulls, like it hinges at L2. So we really get in there with our massage therapist very gently. She's prenatal certified, but we try to do a little massage first and then work with the acupuncture, and it's usually gone in a few visits. So it's pretty responsive to that. But that's when we would do that, continue on through that. And then we do ask, like, you know, for patients to come back prior to delivery if they'd like to do. That's really fun, you know. So we actually do, if they are going to do a vaginal birth, we try to work with them, so to kind of help that transition a little bit. And then after, you know, in postpartum care, we don't usually see patients like that much. I mean, they're busy with the baby and everything like that. We say like once or twice just to come in to do like one postpartum treatment. It's really nice, actually. So
definitely.
Yeah, the lack of sleep and all those things. So
Yeah,
that's like your rest time. So yeah, that's
absolutely.
pretty much our treatment. It's fun because we've seen patients back for the subsequent pregnancies, and we have we still remember how they did when they were going through IVF for the first pregnancy, and then seeing their kids in our office. It's just really rewarding. So that's the fun part of our job. We get to see different generations of
Oh,
patients.
it is. That's the best part when you can help them through the entire journey and then see the fruits of everyone's labor and you
Yeah.
know.
No,
The,
now when their kids start coming to us for fertility, we're gonna feel really old.
oh my God, no! I can't handle that.
So yeah, but I think our oldest let's see person our patient who brings their teenager to us, she's 16 now, and I treated them when they were going through IVF. So I was
Oh my
like, I
God.
remember when you were a little embryo.
Oh,
but,
that's such a
but
nice feeling, though.
yeah, now I'm like we're helping with acne and puberty stuff. So
Yeah.
but
Ooh,
yeah.
puberty's rough, so yeah.
Yeah, I know. Tell me about it. I have four teenagers now, so
Oh my
they're all,
God.
they're all going through puberty at the same time. It's fun. But definitely, there's ways to help with those things. So yeah. So I think we made it through all of our questions, and
Yeah.
I'm not seeing like much in the feed, so I don't know if hopefully we're still live. But if you guys
Yeah.
have some questions, you can
No,
pop them in.
my place
Are you
isn't
see
coming.
my feed is cut off for some reason, so
Oh,
when I
okay.
typed my little comment in, it just stopped with the feed, so I can't see anything. So
Okay. So we had one that says, my acupuncture place doesn't come after FET, but they have experience with fertility. So, and I think that's sort of you touched on that one already, in terms of, not doing it directly after FET, but doing it like 4 or 5 days afterwards,
oh
right?
yeah, definitely just don't go anywhere. There was one study that showed it adversely affected it. I think someone was trying to get to their, or they were doing some study where they were trying to drive to the acupuncturist after the transfer. And by the way, the points are very different. The points that are used immediately after the transfer, they're never done again during the whole pregnancy until the very
Mm.
end because those points are contraindicated. So unless we do them right away, they're not to be done. So you do not want to do those points
Oh,
right after. They're actually to prevent uterine contractions, but we again are not going to, they definitely could have an opposite effect if you're going to do them at a later time
right.
with stronger stimulation. So that's why we just don't mess with that. And after that, we are treating our patients as if you're pregnant. So because you are, in my mind, you did it, yes.
Yeah.
And so so we're definitely treating very gently, not doing any more abdominal points, any of that afterwards, after the transfer.
Got it. This one says progesterone suppository rectal insertion causes diarrhea for me post insertion. Does this result in me absorbing and not absorbing the progesterone? I do not know why. I mean, I guess there's no problem with putting progesterone rectally, but if it's
Mm.
causing a problem, I haven't necessarily heard that, but I would say that yes, if you're having diarrhea afterwards, you're likely flushing out the progesterone suppositories and minimizing or decreasing absorption. I would say that I'm not sure why they're not being done vaginally, but I would say switch over to vaginal would be my recommendation.
Yeah, I haven't heard of that. I haven't heard anybody recommending that to do, but I guess
I
some people.
I haven't either, but
Mhm.
hey, you never know.
Yeah.
Um, have you had any patients after a chemical miscarriage um, not have their period come and resort to needing to take birth control to force it to come? So yes, but you should be evaluated to see if there's something going on. Again, is there a hormone reason you're not getting a period? Is there a structural reason that you're not getting a period, like scar tissue or something like that? You should probably have an evaluation if you haven't gotten a period. After a miscarriage, I would say, give it about a month or two or even 3. Sometimes it can take that long. But in general, I would say you should have an evaluation for something like that. Um, how to deal with anxiety while waiting for the results of the pregnancy test. very tough.
Yeah.
Acupuncture helps, meditation helps, light yoga can help with like light stretching and support of your family and that sort of thing.
Being okay with the outcome, you know, whatever that is, like knowing that you did everything.
Absolutely.
Okay with it. And that's what's really hard to, easier to say than do, right? I know, but that's, I like a lot of the fertility meditations for that, just kind of being at peace with with this decision and with, you know, the outcome, whatever it is. So
yeah, 100%, 100%. Does it make a difference to success rate if a patient gets up immediately after transfer? And the answer is no. There used to be, you know, long time ago, we would say you have to be on absolute bed rest for a week after an embryo transfer, and you know, no moving or anything like that, or lie down for 20 minutes or 15 minutes before getting up or anything like that. And all the studies have shown no difference in whether you know, get up right away or whether you remain, you know, reclined for some period of time. There really is, there's no difference. So most people have to go to the bathroom after transfer because they have a full bladder. So most people go for getting up, and you're not going to, you know, decrease your chances of success by doing that.
the embryo is not going to go anywhere.
No, it's not. Let's see. My doctor doesn't measure progesterone levels pre-post transfer for the reason that levels always, so there's no point. What are your thoughts? So, not my approach. It also depends on what kind of progesterone you're using. So if you're actually not using progesterone in oil, getting a serum or a blood progesterone level is not going to necessarily reflect the amount of progesterone that you're getting. And I think that's also one of the reasons why it plays into why progesterone in oil is really preferred over like suppositories. Yeah, I'm not exactly pre-post transfer for the reason that, I don't know, there was sort of a typo. I'm not exactly sure what they're asking. Levels always. So there's no point. What are your thoughts? In my opinion, if there's, you know, more information to be gained and potentially an intervention that could, you know, help improve your chance of success, I think that's beneficial. So I routinely do it, and I would say just about every one of my colleagues at IVFMD does chest pre and post. But you know, if your doctor feels as though it's not an appropriate choice for you, then I guess that's okay. It wouldn't necessarily be my choice, but doesn't necessarily mean that it's wrong. I just think it is a different approach.
Yeah. And I think I talked to someone who their clinic didn't do ultrasound during transfer, which is actually unusual too. And
that is pretty unusual.
Yeah, but I think,
I mean, that's how it used to be done. I mean, but prior to ultrasounds being available, so potentially that physician may be, you know, maybe a little bit older or more experienced, or maybe they trained when there wasn't ultrasound, so they don't find a benefit to it. That could easily be an explanation for something like that.
Mm-hmm. Yeah, so it really depends on where you go.
Yeah, absolutely. Embryo grading is itself variable. It should be selective and be strictly done. I don't know. That's someone named the embryo artist that is in the yeah. So I guess they're an embryologist or something like that. But yeah, no, I mean, hey, I'm not an embryologist, so potentially my explanation of the 6 BC embryo was not as accurate, but you know, they would certainly know better. But
I can't see these comments, or else my feed is completely stopped now. So
oh no,
okay. Yeah, but Yeah,
And
well,
then,
that's good. Thank you for interjecting, because
of course,
maybe we should have an embryologist on our live one day. That would be kind of fun.
that would be cool. That would be cool.
Mhm.
Actually, this embryo person is answering someone's question. So someone then asked, "What do you think about day 7 embryos?" And the embryo artist said, "Day 7 embryos are being cultured only in conditions when the growth is slow and it's not routine. Few studies have shown to found good evidence of euploidy or having a normal embryo in pregnancy as well." So I agree that it's very well appreciated that a day 7 embryo has a lesser chance of pregnancy compared to a day 5 or a day 6 embryo. That's pretty well appreciated. And in general, yeah, we routinely, if it is appropriate and deemed appropriate by the embryologist, if an embryo is not appropriate on day 6, we will give it until day 7. But then that's the sort of the absolute max that we'll do. So, let's see. Well, I know there's actually a bunch more, but we're kind of out of time here. So maybe we can ask these people to reserve their questions for next time, if that's okay.
Yeah, I mean, definitely we'll be doing another live next week with Dr. Kenneth Gellman in the Culver City office. So
Yeah.
if you'd like to just send us your questions, or you can message IVFMD, we'll definitely get those questions answered as well. And if you'd like to also contact us, you can contact Dr. Bauer at the Boca office, right? Or you're in different offices, but you're.
I am. I'm actually the majority of the time in the Jupiter office now.
Oh, Jupiter. I might keep thinking Boca.
No, because I was initially.
Okay.
We moved a little up north, so I spend a little more time in Jupiter, but I do still also see patients in Boca. So
very nice. Oh, awesome.
yeah.
And we are available for phone consults if you guys have questions about acupuncture. We do free phone consultations, so you can give us a call or schedule online. We have a link on our bio there and on Instagram at FL Complete Wellness, and we'll look forward to speaking with you at that point if you just have any questions at all regarding the process or the treatment or anything like that. So thank you for joining me again, and I look forward to these all. So hopefully we answered you guys' questions, and next week we'll get to even more of them. So
Awesome. All right, guys. Well, if you're interested in following me on Instagram, or if you have questions, you can DM me. I'm Jessica Bauer _fertility doc, and then Dr. Duro is FL Complete Wellness. So hit her up,
Dr. Bauer. I appreciate
Thank you. Talk to you
Bye,
soon.
everyone. Have a good one.
Bye, everyone. Have a good night.
Bye.